Okay, so good afternoon, everyone. Today's town hall, the CALUCA town hall, is on urgent care contracting. This is a topic that kind of befuddles a lot of people. It can be intimidating, and no one's really sure, I think, what to do when they're going into it or when you should redo it. It's I think, a really important topic for urgent care operators and owners. We are lucky today. We have someone who specializes in this, Tammy Mallow. She's the Senior Director of Consulting at Experity, and she's going to present for about 3/4 of our hour on contracting, and then we'll take questions after that. I'll have some questions that some of our members have already sent me, and if Tammy doesn't answer them during the talk, we'll go over those. And if there's any other questions, we'll address those at the end. A couple of things before we get to the end, or before Tammy starts, because I always forget to do this. Our next town hall will be July 8th, and I want to give a plug out to our fall conference, which is happening on the 18th and 19th of September this year in Monterey. So, Tammy, thank you very much for being here and talking about this really important topic. And I'll give you the floor, and I'm going to mute myself so I don't make any noise.
Great, thank you very much for the introduction. As introduced, I'm now the Senior Director of Consulting. A lot of you know me as the contracting, credentialing kind of go-to person in the industry. And never fear, still doing that, just kind of bringing that element to our consulting team, working with Heather Reel and Alan Ayers, probably two people that you're familiar with. But it's fun for me to talk to you all. California, I have so many clients in California. It's one of my favorite areas to work, some of my favorite people. Some of my clients have become good friends. So it's nice. And so I appreciate you having me. The majority of what I talk about today and in any of the presentations I do is really based on my experience. I do some research if I'm not 100% familiar, but the biggest part of it just comes from doing this for several years. And this presentation is similar to what you've seen in the past from me. It's mostly conversational. It's informal, hopefully very informative. And I'm looking forward to some of your questions. I did incorporate some of the questions you submitted ahead of time into the presentation. So hopefully we'll hit most of those for you. While we're talking about contracting, it's just impossible to not involve credentialing because it's such an important part of it. So I'm starting out today with some urgent care credentialing myths. I wouldn't think that most of these are surprising to you, kind of depending on who's in the audience, but let's walk through those. And keep in mind, all of these statements that you're looking at are myths, or at least in part falsehoods or misunderstandings more than anything else. So the first one says that providers credentialed in a market do not need to credential when they join a new group. Unfortunately, for the commercial payers, if you join a group down the street, most of the time you're going to have to be re-credentialed. There are, of course, always exceptions to all of these things. The second one says that most commercial insurers are going to retro payments back to the first day a provider saw a patient. Unfortunately, the truth of that is that they retro payments back to the date the provider was first credentialed and effective with that group. The third one is a very popular one, that the term locums means providers working only a few shifts a month, so they don't need to be credentialed. Well, there are some commercial payers, and of course Medicare in some cases, that absolutely allow that. There are also equally or more payers who don't. If the payer requires credentialing, that includes locums. I always tell people it includes full-time, part-time, and sometimes. It's a good way to remember it. The fourth one says that the payers usually don't require mid-levels to be credentialed. They just bill under the physician. You're going to see a slide here in a moment that shows you what can happen when you do that, when you shouldn't. Owners can elect to credential a provider based on their employment status. Same thing, full-time, part-time, or sometimes. That means contracted or employed. It's not up to us, unfortunately, but it's up to the payers. Now, if a group wants to provide urgent care and primary care under the same location, tax ID, etc., they just need to ask the payer for a dual contract. yes, you should ask the payer for a dual contract. We're pushing for those for a long time. However, you shouldn't assume or even count on that being the fact. They're going to want to do a separate contract. Payers don't have the authority to impose penalties, recoup payments, terminate group contracts, or dress me in an orange jumpsuit. So, this is a little tongue-in-cheek, although it's very serious. They absolutely have the authority to do those things. Your jumpsuit might not be orange, but I think you get the picture. And then finally, my favorite, credentialing is a simple process. I'll just take care of that in-house. So most of you know how I feel about that. So here, again, not to be starting off my presentation as Debbie Downer, gets better sort of after this. Let's talk about the False Claims Act and just the importance of this. It's not, it's not just following the rules of the payers, but also this False Claims Act. And I've just thrown up some examples. These are just a few examples of penalties, both large and small practices, big practices, chains, independent. That last one is in the news just recently, and that was startling. I mean, that's a lot of money. So it's not something, that we want to do, and we need to stay on top of. When it comes to being concerned about that in urgent care, what we see most often in terms of violating the False Claims Act or anything similar to that are things like failing to have a physician on site if your payer requires it, billing non-credentialed physicians under credentialed physicians' name and NPI. That is a huge no-no. Billing mid-levels out under their supervising when the payer requires credentialing, same thing, big no-no. And then billing out additional service locations that have not been formally added to existing contracts. We're finding more and more where in markets, the payers are not just adding new locations because you want to. So we have to be very careful with that and vet that information. So how does a payer even know this is happening? That last one that I showed you at the bottom, that was a whistleblower situation. But there are other ways too, lots of ways, but here are a few here on the screen for you. A big one is when the credentialed providers in your group, where their utilization spikes. So all of a sudden they're seeing, theoretically, because they're billing for double the patients that they used to see, or maybe they're filing claims from one location and another. That's a huge red flag, obviously, to the payers. Sometimes representatives in certain markets will just visit the center. They may ask for a provider schedule that they'll compare to their credentialed roster. And then another thing that we don't always think about maybe is that patients look at the EOB and they see a provider name that they didn't see, and so they call into the insurance company or to your office. And of course, the consequences are very real: recoupment of payments, suspension of contracts, penalties, and serious legal consequences. So how do we keep that from happening? Staying current. I mean, that's really the only way. Payers change their rules all the time. Whenever I do a presentation like this or I write a report for someone, I always say, this is the information at the time I wrote this, because it changes. It's kind of like the speed limit, though. Just because you don't know the speed limit, you're still accountable. Same thing for these rules and regulations. You're still accountable for them. So what we're seeing sometimes at the payer level that could get people in trouble is not knowing that they've changed the physician on-site requirements, or maybe they require accreditation or certification now. Again, I mentioned earlier about the new service locations. We can't just assume that's the case nowadays. We're seeing more site surveys being conducted, and then this back and forth with when a provider should be credentialed and when they shouldn't. And what we find there is sometimes we'll get a notice and even the representatives didn't know the notice was going out. So that one gets very tricky. And we're not always notified properly. And I say we, I mean, we as a vendor, you as a provider who may do your own or have another vendor that does it. You may have switched services, so those notices go to old addresses or to providers who just see them and think somebody else is going to take care of this. So you may not even know there's an issue until you try to bill for or submit a new provider or a location, and then it comes up. What we do find, though, is most of the payers are working with us. They grandfather in certain groups when big rules change, or they offer a grace period, like for accreditation, to get that done. They're not completely unreasonable. You just have to understand the timeframes and make that happen. It's really important to remember to always contact your payers for information specific to your contract I'm going to show you in a few minutes all the different contracts options. And you could call and say, I'm in urgent care, what are the credentialing requirements? And then look at your contract, and you're actually contracted differently. So those rules are different. If you find that you're out of compliance, building a corrective action plan, just proactively correcting the issues would go a long way with the payers to reduce those consequences. And then, of course, just create some type of system, some type of program to stay current. I think even if you use a vendor, I used to be an operator, I would still say, have a system set up for yourself internally too. It's just such an important piece. All right, let's move on. Primary care versus urgent care, the $15 million question. I think that as we have struggled a little over the years in urgent care to be creative and new, we've looked more and more at adding primary care, and also because patients are coming to us needing primary care, so it makes sense. I'm not going to go through all this with you. I mean, really what we're looking at most of the time when groups ask me this is, should I do it? Should I do both? If I do both, how should I do it? And then what's the difference in the revenue I should expect? So I'm going to hit those highlights. You can kind of see the difference in the credentialing criteria. If you want to know more about that, I can certainly answer those questions. But let's talk about the revenue in urgent care as opposed to primary care. In your market, as far as I know, you primarily work off of fee-for-service agreements. In other markets, it's almost across the board flat rates. And I know you have some of those, but this really applies to fee-for-service agreements. If you get a fee-for-service agreement for a primary care contract, it's probably going to be the exact same as your urgent care, meaning the rates are the same, the percentage of Medicare or however they establish the rates. But we all know that typically urgent care generates more revenue per visit than primary care. These are made up numbers just here for demonstration. And the reason is the way we operate in urgent care. We see more new patients, we see higher acuity patients, we do more ancillary services. So by nature of coding, when we see more higher level and a primary care sees more higher level, level twos, we see more level fours, that by nature is going to generate more revenue. So it's really just the way you practice. You could theoretically take a primary care contract and fee schedule and function very similarly as an urgent care and generate the same kind of revenue. So the ideal situation, if you want to do both, is dual contracting. Very, very rare. That's the red guy jumping up and down. That's the dual contract guy. In my experience, most plans will not contract as both primary care and urgent care under the same contract, tax ID, legal name. There's lots of reasons. One of them, of course, is the concern over steering patients to the service line most lucrative to the provider at that time with that particular patient. The other reason is just sometimes their contracting systems and templates they don't know how to do that. They don't know how to recognize that. So if your competitors are doing both, or some of you that are listening, I know are doing both because I've helped you do that, they're probably operating under one of the workarounds I'm going to show you here in just a moment. But I did want to mention that the only time I've ever seen a true dual contract was in California. It might have been with one of you listening. So when I talk about options, I'm talking about contracting as an urgent care. And if your contracts allow and the scope of your providers are in alignment, offer primary care type services under your urgent care contracts. That can be a little bit more tricky. Contracting as primary care, and adding urgent care services is a little bit easier to do. And I say easier, I mean from a contracting perspective. We generally, well, not generally, I've never seen a primary care contract that says you can't do radiology if you have that ability, that you can't stay open extra hours or do laceration repair if your providers are capable. So there are other limitations, but as far as the services piece goes, there really isn't. Or like I said, you can do both. Have a separate tax ID, separate address, suite A, suite B is what a lot of people do, separate providers, contracts, policies and procedures. Policies and procedures, especially around how you decide where a patient goes when they come into the clinic. And clearly it can't be because you're going to generate more revenue or their copay is going to be less. There's some sort of financial incentive for them to go from one to the other. So it's important to remember that this can create confusion. That's your patient walking around going, are you primary care? Are you urgent care? Or it could be your front desk staff saying, I don't know what we are, if we're primary care or we're urgent care. So you have to be prepared for that. So even though you can't necessarily get a dual contract, you can have a mixture of primary care and urgent care contracts, meaning you can contract with one plan as urgent care and another plan as primary care, all in the same office. But why would you do that? It seems like a crazy thing to do to create this confusion. But sometimes you'll find that the market's closed to urgent care. If that's the case, you might want to look at a primary care contract. Maybe the group or the provider, for some reason, doesn't qualify for an urgent care agreement or to be credentialed. And maybe it just comes down to rates. There are several different reasons. I'll get this guy off the screen in a minute. I know he's distracting. Some of the limitations, though, with moving into a primary care environment is if you have urgent care in the legal name, we have seen some payers say that you can't be an urgent care legally and practice in your legal name and be a primary care. I think that's up to the reps. A board certified emergency medicine provider rarely can get credentialed as a primary care provider. The primary care market might be closed too. We do see that sometimes. You really operate differently under primary care than you do urgent care. You may have to have a panel of patients. There might be some capitated agreements, and there's just really a lot of different operational components that go along with that. But I just wanted to kind of give that to you at a high level. So I mentioned that California was my favorite, one of my favorite states with some of my favorite clients. I think that's because of the people, not necessarily the process. There are a lot of nuances that are specific to your market. And some of these things we see in other markets. But when I polled our staff and I said, tell me the things about California that come to mind, you know, that you have to keep in mind when you're especially starting a new group. And the fictitious name permit is one of those. That does create some issues. And we do get a fair number of prospects that call us about starting in urgent care in California that are not aware of that. The mere proliferation of NPNs is something I've never seen before. There are so many, as you know. The same thing with the Medicaid, Medi-Cal in your regions, MCOs. As far as I know, you have the most in the country. So then what happens is you end up with the most payers on your payer list in the country. Overall, the average is about 15, maybe 18 in other markets. In California, we have clients that have over 30 payers. So I put that 25 to 30 plus just as a number. And also it's the only place that I know of where Anthem, Blue Cross, and then Blue Shield are two separate contracts. Haven't seen that before. Anthem requiring two physicians for a group agreement. That's really created some problems for some of our startups, especially the small ones where there's one physician involved. And then they might have a nurse practitioner or physician assistant join them. Having that second physician can be costly and may not work for a small startup. So that is an interesting nuance specific to California that I don't think I've seen other places, even though we work with Anthem in other markets. Also, Anthem has an admit policy. It's a form that you have to fill out when you're just getting started up, outlining your admit policy. Do you have somebody that will admit for you? And if we have a new group that doesn't know that they may need that, then that can take some time and delay opening to get that all taken care of. An interesting thing that I've seen, this was just in this last year, I believe, where Regal asked one of our independent urgent cares to be exclusive to them, meaning you can only join our IPA, you can't join any others. And then this other one, I'd really like to know, you can send me an email if you like, if any of you have experienced this, where Medi-Cal reaches out to groups in underserved areas and offering Medicare rates if they will enroll in Medi-Cal as a provider. That's pretty interesting, and I want to know more about that. TRICARE West being open and closed and open and closed. When I prepared this presentation this week, it was closed, but could be open today. We've been seeing TRICARE close in markets, which is really new to the last couple of years. And then, of course, Kaiser having such a big market and being exclusive really hurts some of our urgent care centers. And like I said, California has the only true dual contract I've ever seen. So lots of interesting things going on in your market. So that's probably part of the reason that you have me talking with you today, is there's a lot to know. On the list of questions that was provided to me when I was putting this together was some questions around MPN. So when I was knee deep in contracting, credentialing, and doing the paperwork and that sort of thing every day, I was intimately familiar. But it is so confusing if you don't do it all the time. I had to go back and refresh my memory. So I put this link on here for you in case you needed to refresh your memory, or you have some staff who are not certain how that all works. It was great information. The question was really around what are the advantages and disadvantages of being part of an MPN. And from my understanding, it's basically sheer volume. If you want access to those patients, then you have to play ball. Most employers that have their own are very large employers, so that equals volume. Just the sheer volume of the number of MPNs in the market alone make it hard not to join. Some studies have shown that claims closed more quickly, so that's a good thing. In terms, some work comp claims, as you know, can go on for years. But the attorney involvement went up, so the claims are closing more quickly, but attorney involvement went up 5%. And now that can be an issue sometimes just because of paperwork, but that may have something to do with them closing more quickly too. When we talk about access to volume, as you know, anytime you're accessing volume, you're joining a network, you're going to have to take a reduced fee schedule. So the incentive to join any network is volume. The issue is how much of a discount are you willing to take? So I found this online. This is a few years old, but I think it does a good job of explaining what happened when work comp was managed by PPOs, then through that MPN transition, and then what it looked like once the MPNs were fully implemented. If you look, for example, up here at the Bay Area, being in network with an MPN results in a 15% difference between being in network and out of network under the MPN. Under the PPO, it was 17%. So you could look at that so many ways. I've done that over the past few days, is looked at this inside and out. But essentially what that means for the payer or the providers in this market, you're taking less of a discount. But the whole purpose, supposedly, was it was all around healthcare cost savings. So clearly that hasn't worked in that market. But you can go on down the list and see, that it's not the same in all markets. I read that Los Angeles has the most claims, but you can see here that their network and non-network difference is 0 after a full MPN, and it used to be -16. So you'll get a copy of these slides and you can kind of look up your market. And I have some supporting information that I can provide to you too if you want a closer look at this. So I realize most of you are probably existing providers, and not necessarily startups, but if you are looking at adding clinics in new markets, then you would be considered a startup. If you are, or if you are a startup, we may actually have some people in the audience that are startups. So I just wanted to talk about this just briefly. One of the questions submitted was, what is the best way to know the payers in your local market? And that is through a market study. You're going to hear me say that word a few times today, and I'll go into it in more detail in a few slides. The market studies will show you the revenue per visit by payer in your market, what are the credentialing criteria, what are the covered lives by product in that market, that's really important, and network access. So that's critical. If you're thinking about going into a market and you find out that a big payer is completely closed, that's going to probably change your plans. When it comes to negotiations, this question was submitted as well, it's not great news on negotiating at all, but it's really not great news on those initial negotiations. Unless you're part of a health system or a large group and you have some meat behind you, so to speak, as a single site operator, it's really hard to do much in today's market with those new contracts. So I'm going to talk with you a little bit at the end of the presentation on what to do when they say no. If they say no to a raise, if they say no to access, or any of those kinds of things that you're trying to negotiate with the payer. And then the other question was whether or not you can negotiate rates with Medi-Cal and Medicare. 99.9% of the time, the answer is no. The exception I've seen is what I showed you earlier, where if that's accurate, that Medi-Cal is offering Medicare rates in some markets to generate some provider interest. When it comes to work comp and NPN application and negotiation, that whole process for a startup or entering a new market, it's very similar to that of the commercial process. Your message to the payer might be a little bit different about what you're going to do for their work comp and OCMED, but the process is the same. And some commercial insurers like Aetna have your work comp and NPM products actually included in their main agreement. You just have to make sure you check the right boxes and know what you're looking for. So I know that a big part of what you wanted to talk about today is negotiation, or in this case, renegotiation. I would say that before you do that, time frame wise, I would give it yourself as a new provider a couple of years, 3 years maybe, to really get some data behind you and some experience. But before you do that, get organized. I mean, that's the important piece. Get copies of your contracts and fee schedules. If you can't get contracts, then at least I'm going to show you some information that we want you to be able to put together in a report for yourself. I'd like for you to get copies of your contracts. It's just always good to have those. And I'll show you some reports that will help you be more organized. And I can't express enough, when you're going to the table with a payer, you need to know what's in your agreement. You need to know what type of agreement you have, what are services allowed or not allowed, what's the place of service that you use on claims, do you have a case rate or a fee for service? You really need to know those inside and out. And mostly you need to determine if those are still right for your practice. I think it's probably safe to assume that those of you who started years ago, that your practice has changed over time. Hopefully things have changed in the right direction, but your contract might not be right for you anymore. And then there also may be products in the agreement that you're non-par with for some reason. When you first negotiated your contract, you weren't eligible, it wasn't open. There's a number of reasons, but you want to know what they offer and what you are part of and what you're not. And then that market study that I talked to you about, you need to know what are the top payers in your area, what are they paying on new contracts, what are the credentialing criteria. You're going to know what your rates are, but you need to know, what does the market look like today? Is it better? Is it worse? Because that's going to help you decide if you want to go out and open that door for negotiation. And then looking at the top payers in your area, the list is going to tell you if there's anything missing. Maybe there's a payer you weren't aware of, or something's changed or come along. Oddly enough, the most difficult piece of this that I've listed out so far is getting payer rep information. I hear every day, well, you don't have a human rep anymore. There's nobody I can talk to. They want me to email an email general box, and then I may or may not ever get an answer. So do what you can to get a name, a current email, phone, whatever it takes to get in touch with that person. And I would start that process early because it can take considerable time. And then regardless of whether you've been open 2 years, 3 years, 7 years, you have to have a compelling reason, a compelling argument request for renegotiation. So that's when you're truly ready. It's not just if it's time in your contract, but are you at a point now where you can truly demonstrate a valid reason for an increase or a change in your contract? When I mention contract information, the pieces of information that you really need is exactly the type of contract you have, what version is it, and what is the legal name for you on that contract. What products are included or excluded, what's the effective date and the termination terms, fee schedules, credentialing requirements, and then any out-of-network plans that you have that you might want to join. So what you see up here on the screen, it may be too small for you to see, but it's really for demonstration to show you that in the contract, it will list out the products. People call them different things. I call them products. The main, like let's say if this was, I don't even know what it is, Blue Cross. If this was a Blue Cross contract, then it's going to list out for you all the different products that Blue Cross offers under their main contract. And then others will list any that you're not a part of. So that's important to understand how those are listed out. Some are easier to find than others. And then when I mentioned termination terms, oddly enough, whenever you are renegotiating with a payer, that's the term, that's the section that you need to look at, because it's going to tell you the term of your agreement. So this one, for example, was 3 years, and then it renews every year unless one of you, come to the table. And then it goes on to say that you have to give a 180-day written notice. That includes, even though it doesn't say it, that includes renegotiation, because you are, in a sense, terming the initial terms and creating a new one. So that 180 days is a long time. It's hard to keep track of. I mentioned earlier types of contracts. I just threw a bunch of these up on the screen. There are probably more than this, but that's how confusing it can be. So when you're looking at your contracts, always look at the exact type of agreement, and it should be somewhere at the top or in this initial language. The name of the urgent care, your urgent care as you are contracted with this payer, should be somewhere on the first page, and then your effective date. And then you create this high-level report. So it's just a snapshot of your contracts. And if you're an Experity client, you've probably seen this before, at least something similar to this. Now, I didn't have room to list all of California's 30 different payers out here. So this is just a quick snapshot, made up numbers for demonstration only. So for example, with Aetna, the term notice is you have to give 90 days. And so in this example, if I wanted to renegotiate this contract and I haven't already let the payer know, well, I missed the boat because it's 90 days. So I'm gonna have to wait until next year. And 99% of the time, the payers are going to hold you to that. So we see 60 days, 90 days is probably the most common, but we do see a fair amount of 120. And that 181 that I just showed you a few minutes ago, that was a snapshot of a real contract. So that does happen. We want to know what are the credentialing requirements for our specific contract type. So it could be facility, ancillary, provider group agreement, and that's what dictates your credentialing criteria, not how the services you offer. What does the fee schedule look like? What place of service am I using? And then exactly how does my name appear on the contract? You know, if you wanted to build this out, you could also put your tax ID, your NPIs, maybe your address, just so you have it all there at a glance. Yeah, we're doing on time. All right. So when we talk about top payers a lot of the time, and understanding what this means and how it's going to be used is going to impact which payers you negotiate with, which ones you kind of back off of, or even which ones you just market to. So understanding the top payer piece is dictated by what results you're looking for. So the payer, for example, with the largest market share may not be your top payer if you're trying to determine who has the best rates, because often those with the smallest market share offer the best rates. So if I want to know who pays me the most, then that would be my top payer, and that's who I want to reach out to, maybe for some marketing. I'll talk about that in a few minutes. So you have to define the best payer. Is it quantity or quality? Again, it depends on the project you're working on and what outcome you're looking for. So there are two ways to look at that. It's pretty simple. You'll see me say average revenue per visit or net revenue per visit. Really what I'm looking at is just after everything has been paid on a claim, the insurance is paid, the patient's paid, the write-offs are done, what is the bottom line? So for example, on this side of the report, I ran it by volume. Again, completely made up numbers. Blue Cross Blue Shield gave me the most visits in this time frame, and the average revenue per visit from them was $115. The insurance paid $92, the patient paid $23, and this represented 70% of my volume. So obviously Blue Cross is very important. Then you flip it around and say, okay, well, Blue Cross sends me the most patients. Who pays the most per visit? And in this demonstration, again, completely made up, was Humana. And they pay me $135, but they only sent me 117 patients. So that was 1% or less of my total visits. So again, depending on what your goal is, what your project is, you're going to look at it this way or this way. However, before we go much further into that, I really want you to stop and think for a minute about the fact that renegotiation may not be the first go-to. What if you could give yourself a raise? Just think about how much easier it is to get the most out of your current contracts instead of spending all this time and energy for the small percentage of possibility that you're going to get a significant increase from your payer. Don't mean to discourage you from that. We're going to talk about that more, but I just wanted to step back for a minute and have you think about this. So are you, is it proper coding? Are you clear on covered and non-covered services? Do you understand your E&M distribution, new versus established, ancillary income? Are you looking at all of that? A good way to start is just to look at the contracted rates by code versus actual. Now, as easy as this sounds to get, sometimes it's very difficult. I use Cigna because in the markets that I'm familiar with, they only have one product. So it's pretty easy to look at your Cigna codes, what were you contracted for, and what are you actually generating per visit. For the payers that have all of those products under them, that have maybe multiple fee schedules, it gets a little more messy. But I think you could still look at your most high volume payers and the most high volume products that they have and still do this exercise. But it's not something you just call your billing team and say, hey, send that over to me. It's a little bit more complex than that. But I think in some cases, it's worth the exercise. So what I'm showing you here is, for example, I'm contracted with Cigna on an O3 for $95, but I'm only generating $90. So where's that $5? Is it coding? Is it technology? Is it, I don't know, maybe too many write-offs? What is the problem with the difference in my contracted rate and my actual rate? Anytime it's more than $5, I would like to really take a hard look at it, because you could give yourself a $5 raise on every Cigna visit you had. Just think if that was Blue Cross and those 7,000 visits we just looked at in a short time frame. If it's $1, I wouldn't worry about it too much, but anything over that, I would take a good hard look at. So if you're leaving money on the table, let's fix it, give yourself a raise. I also just wanted to point out, you must be clear on less than billed charges. That might be where this comes into play. If for some reason the EOBs or the claims are not going out with at least the $95 on it for an O3, then the payer is going to pay you less than billed charges. That's true on a flat rate too. All right. Other ways to give yourself a raise. E&M code review, your distribution versus the industry. And if your distribution is significantly off or even a little bit off, again, take a look at your technology, your provider documentation. Do providers need some training? Do the billers or coders need some training? And that might be all perfectly in line, and yet you're still off from industry. And that could be because your patients or your community doesn't really understand how to use you, that you have the capability to do much more complex things, and maybe they're going to the emergency department for those things. So that might be some marketing. A lot of times marketing is the key as much as renegotiation or more. Again, I know I keep saying this, but I can't emphasize enough that these are made up numbers. It's just purely for demonstration. Might be true at this time, but it's not current and just for demonstration. Also look at new versus established. If you, in urgent care, we typically see more new patients, and on a fee-for-service agreement, that's the revenue generating piece for us. If you find that your practice is heavier on the established visits, then again, it might be a good time to dust off your marketing tools, because you can really see the financial impact here when you're heavily weighted on the established side. That might change a little bit with the new coding. I only know enough about that part to be dangerous. So we've had some of our Experity experts do some really good webinars on those pieces. All right, let's talk about the ancillary effect on our revenue. This is a really busy slide, but it has good information, and I kind of like the little guy that runs away from the needle, so I left him on there. Think about this for a few minutes. Findings have shown that the average clinic, just the average run-of-the-mill clinic, does their job, does it fairly well, increases their revenue $28 a visit on 70% of their new visits and $26 on their established. Higher performers, those who are a little bit more sophisticated, maybe have done some of the things that I just talked about, use technology to the maximum, all those kinds of things, we're bringing in as much as $50 and above on 80% of all of their visits. So clearly ancillary on a fee-for-service agreement is important. They contribute significantly to our overall revenue. So are you documenting, coding, billing? Are you average or below, or are you a high performer or somewhere in between? Another thought I had when I was writing this, and this was just a side thought, was, and I actually did this exercise for a client years ago, was we looked at their fee schedule to see what were some of the higher revenue generating codes, and then looked to see if that was a service we could add, or maybe a service we already were able to do and the community didn't know we could do it. That might be worth looking at. I always go to the wellness, annual wellness, for example. I realize that not all urgent care centers are equipped to do a complete annual wellness physical, but if you are, and the contract allows, some of those can be several $100s. So I just challenge you to be kind of creative with that piece. As long as it's in your contract and you have the scope, that's what it's there for you. All right, if you decide to move forward with negotiation, and I realize I'm getting tight on time, so I'll speed it up a little here. One really important thing to remember is that our traditional negotiation tactic of saying all the things that urgent care can do, like reduce overall costs, reduce emergency department visits, we have x-ray, we're here after hours, we do procedures, that's expected. The payers just expect that now. That doesn't separate us from the pack anymore. So it's important to remind them of those things, but that's not going to get you a raise or get you in network. You have to have that compelling, well-constructed request we talked about earlier. So make sure you understand the term language that we mentioned before. That's extremely important so you don't miss a time frame. Understand that there's a possibility you could get lower rates. That has happened. That's a real life in the trenches experience that I almost had. What I did, thank goodness, was I just had an informal conversation with the rep about it first. So we didn't submit a formal request. So that saved a client $30 a visit. I think it was a flat rate. So and also have that current market study so you can see if the rates are lower now than they used to be, and that can help you make the decision. You want to show financial impact. What financial impact are you having on the payers? And then put that well-constructed request, compelling request together. Have a number in mind. Sometimes I share the number with the rep. I go, hi, of course, that's just what you do. But sometimes I just want to lay it out there. Here's what we're looking for. We're significantly underpaid, or we're just asking for something minor. So, it's really just up to you and your style. Do you want an across-the-board increase, or do you want it by code? It's really important to point out that some fee schedules that are based on a percentage of Medicare pay different amounts of Medicare, percentages of Medicare, depending on what the code is. Logically, according to the payers and I guess economics, if 99203 is a code we use a lot in urgent care, then it's going to be a lower percentage of revenue that the payers come out of the gate with. This is just another example of looking at all of the codes that you have, probably the top 25, what kind of volume are you seeing, and what is the revenue per visit for those codes. And then you might look at some of these and say, that is just not enough for a level 4. I need to see what I can do to bump that up with the payer in your negotiations. Here's the payer market study I've talked about several times, and I'm glad we're going to have time to go through it. The payer market study, I call it a payer landscape review sometimes, but it really gives you the opportunity to understand which payers have the market share, the majority of the covered lives, the revenue per visit that they're paying on average. Are there any barriers to the market? What's the credentialing criteria? That network access issues is huge. So if you're thinking about moving into a new market, you need to know if the networks are narrow, they might even be closed. This particular example was for Florida, only because I recently did this, changed all the numbers and the zip codes. But the first level is to look at this. Then when we find out, for example, that Blue Cross Blue Shield of Florida is not completely closed, but some of the products in their agreements are closed. And so if you were looking at moving into this market, you would need to know what this means. So these are open, these are closed. well, what is the covered lives that are represented? Is that enough to make me decide to not be, to not go into this market? Or maybe it's all Medicare and I'm a pediatric urgent care. So then we're able to look at it in more detail by zip code, the number of covered lives each of these represent in recent times. So I think that I kind of, again, have to rush through that, but I think you can see the value of that. So when you're going into a market, when you're going into negotiations, these are the kinds of pieces of information that you need. All right, if they say no, when they say no to renegotiation, to your initial negotiation, or to access to the network, number one, get the reason in writing. Is the market at capacity? Do they have an exclusive agreement? Are they telling you that the rates are competitive? So then you know what you're dealing with when you write an appeal. First and foremost, make sure it's worth the fight. It's going to take a lot of time and energy. Is it worth the fight? Sometimes if it's a narrow network, the rates are not going to be that great. But if they represent a high volume, then it would still be worth it. If they tell you that it's exclusive to a health system, or maybe the payer has some ownership in their own urgent care centers, it's a little harder then to negotiate your way in. So you might see if you could join through the health system that they have exclusive agreements with, or maybe an IPA, there might be some other way in. Just another quick reminder that our usual raw urgent care is not a viable appeal anymore, unless you would be the only provider there. If they tell you the market's at capacity, research that market. Unfortunately, with COVID, we did see some closings, and then just generally some urgent cares close. When people retire, they move on. Maybe somebody comes in and buys them out, and then doesn't reopen. Lots of reasons. But you can go on the provider lookup tool. Let's say you're looking at Aetna. Go to the Aetna provider lookup tool, ask for a list of urgent care providers within a zip code, or however you want to define that, and look at those and see if just by living in that market, if those are still open. Maybe they reduce their hours. Maybe they really don't have radiology. Maybe they're not even open anymore, and they never bothered to tell the payer that they were leaving. So the market may not really be at capacity, but always check that out. I really like the idea of involving local employers who want to use you. So I'll use Aetna as an example again. If you have a local employer who has Aetna as their employee benefit, and you're close by, they really like you, they might do an appeal on your behalf as well. And then that kind of goes along with just tracking the patients that come to see you or make inquiry that have that insurance, so that you can use that in your appeal. A quick note is, if they tell you, the payer tells you, we'll let you know when the market opens up, that's probably not going to happen. So I would just continue to be proactive with that piece. Another couple of things is, if the payer says they're not going to increase your rates, I would then use that other report that we talked about earlier, see if there's some payers out there with high revenue per visit. You're not seeing very many of their patients. Go find out who those employers are, market to them, try to get that business into your clinic. And then you're working, smarter, not harder. You're generating more revenue per visit, as opposed to you're still going to be increasing your volume, but not proportionately. And then the other piece would be to, obviously, if you're out of network, bill out of network. Sometimes that works out well for groups. It depends on the market you're in. Out of network pays better, but patients like to go, to physicians and clinics that take their insurance. If you have self-pay options, let them know you have affordable alternatives. Generous flat rates or tiered rates, membership programs, the idea that it's fully transparent. When you come see me, you're going to know exactly what it costs you. And then, as far as just getting that information out there on your website, if Humana is who you're really targeting, advertise to those people. We take Humana. We are Humana providers. You might also add some information about your affordable alternatives. Give a phone number they can call to find out what those look like. A link into your website about more information on those things. So again, it does sometimes go back to marketing and using the tools that you have already in place. Then another quick note, I'm only 5 minutes over. That's not too bad for me. There are a lot of questions about MCOs, Medi-Cal MCOs, and how to find out who those are and in what areas they're in. So I found some websites for you. One of these takes you to a map like this. I know it's very tiny, but it lists out the member plans. I think I can zoom in here. It lists out the member plans, and then there's a guide that shows you what county those are in. And there's a really nice grid that lists I think it lists the representative, but it definitely lists the address, phone number, website, that sort of thing. Another question was, can we share rates between each other so we kind of know what the market is? And that answer couldn't be more of a no. So all of your agreements are going to have something like this that says you have to keep the rates and how you develop those rates in other terms confidential. And in my experience, they will hold you to that. I recently just reached out to several payers about how they were not paying for COVID services and how some of the others were. And so I just screen printed some things from their own websites. I took a few things from actual templated contracts like this, but it doesn't have anybody's name on it. You can't even tell what state this is in. And I got a couple of nasty emails back from the payer saying, you know, you can't share what Aetna does with COVID with Blue Cross. But it was, I think they thought I was a provider, but it was really just purely for demonstration, pulled right out of the website and templated contracts. But my point there is they do take that seriously. I've listed some information here too about Experity Networks, not really an advertisement, but more than anything to let you know that I'm part of a team that's looking for alternative revenue sources. We have a program that's going to be launching very soon that will offer a flat rate to our clients at time of service. So there's not RCM involvement, designed around foreign travelers and a nationwide membership program. So wanted to give you that information, and then I'm going to turn it back over to questions.
Thanks a lot, Tammy. That was